drew the short straw in your group and you are the presenter from your table, if you could make your way up to the front. No? No. We're going to do this verbally. You're going to walk through the crowd. So just, you can all kind of gather up here. The gathering storm. Oh yeah, come on. It's good. Beth, it's good. It's good. It's friendly. Yeah. Yeah, that's right. The first 5 people get chairs. The second 5 have to stand. There you go. Susie knows. That's... Not ready yet. I'm going to be very diplomatic, and I'm going to go down through the numbers. So we're going to start with the first breakout group. No, we're not going to start with the first group?
I'm number 10, and I'm sticking with it. I'm the closing.
If you want to be passed over, I'm happy to let someone else. Collin seems ready to go. All right, so what do we have? 1, 2, 3, 4, 5, 6. Do I see 7 walking up here?
I'm number 10.
Well, yeah, but we literally don't have 10 people. So we're still missing a few representatives. That's fine. When I call you, all right. As long as you're on your way. If you want to sit right there, that's fine. Yeah. All right. Look at Collin. Look, see, that's creative. Okay. All right, folks. Again, thank you for participating in the breakout groups. I walked around. Everyone was really engaged. There were even some bare-knuckle brawls, some intellectual debate. It was all good. But here we go. So the outcome of each of these breakout groups was to create a lot of ideas, but then to get to one that you might want to share with the group. And we're all going to listen and hopefully detect some common themes and some ideas that will inspire us for the rest of the day. We'd like to get through this as quickly as possible, not suggesting you have to rush it New York style, but let's just kind of get through it. We're not going to take questions necessarily. We're just going to share your ideas, and then you can chat with your colleagues at lunch afterwards. So ideally, 2 minutes or so, 2-3 minutes walking through your 4 steps of your research topic. And Collin, what number are you? What group number do you call? 9? All right, so since Collin's right here and is graciously offered, I'm going to let him go first.
Yes, thanks. So I was graciously volunteered. So we had a good discussion in our group, and I think we identified some areas that are fruitful for further discussion. The broad problem that describes what we discussed was that healthcare is increasingly being shifted to the home. So the length of stay for many patients is going down, but healthcare delivery has not followed in the same way. So that patients get discharged and with very serious diagnoses and often get readmitted and so forth, and that to some extent is a fault of healthcare delivery. So there's an open opportunity, and in particular, to develop technologies that are very ambitious, that are in some sense invisible to the patient and the patient's family, so that they can use it with the least amount, so that it's not very obtrusive. And this technology should be able to monitor data from the patient, and that's physiologic data. So, as opposed to Holter monitors and other sorts of things that are used by cardiologists and family practitioners, things that can record other data, such as how ambulatory the patient is, pulse oximetry being another thing, and including to some of the standard measures like heart rate and so forth. So with this monitoring, you can also hope to invent some preemptive things. So you can do preemptive medicine, so that patients, by obtaining all of these data, and that someone may be at risk for a fall, let's say, and a hip fracture, being able to intervene by having appropriate people come to the home and so forth. Right. So there are a number of challenges involved with this endeavor. We want to involve not only the patient but the patient's family, because they provide, and the patient's friends and so forth, valuable information that can be used to assess the state of the patient and to prognosticate for the patient. So in some sense, this system or device has to be capable of involving people at different sites. So the patient may live in New York and they may have family members in other parts that are separated from New York, but you want to include their input as well in terms of evaluating the state of the patient. So not only are we talking about monitoring the physiologic state of the patient, but involving input that in many ways can be intangible from the patient's family and other people that are involved in the care of the patient. Whatever the system has to be low power because it has to be able to work for long periods of time. It has to be reliable, easy to use, and not obtrusive, which is sort of what we mean by being ubiquitous and invisible. Oh, yeah, sorry. And so the last thing is that as a test bed demonstration, we talked about a group of patients, bone marrow transplant patients, which are typically sent home after a few weeks, still very ill and have a high rate of readmission for infections and other things. And we thought that this would be a good patient base to test these things.
Great. Thanks, Collin. Just want to keep it to 3 minutes if we can. Are we ready? Team number 1? Balboa.
Supposed to say who I am? Okay. I'm Deborah Estrin. I'm a professor of computer science at UCLA, and I run an NSF Science and Technology Center. This is nobody's fault but my own, and all good ideas are theirs, of course. And so our problem statement was rather general. We'll get more specific by the end of my 3 minutes. Problem statement, data sense making, a term we borrowed from somebody not in the room. For patient-centric care, and we mean data broadly construed, clinical measures, journal articles, individual data streams, behavioral data, social, and so forth. Approach, rather obvious in some sense. We need approaches to analyzing existing data from natural language processing to dimensionality reduction techniques, the gamut of data fusion issues. We need new types of data, sometimes called life logging, sometimes called personal data streams, from activity location traces to ecological momentary assessment inputs to people's search queries, including semi-structured sources, and including things like teachable moments from clinical interactions. So new sources of these data. Again, all of these are rather patient-centric. Of course, user-centered design in the design of these new systems, and across these, and even in the definition of them, we see an important part of the approach is a common, really transdisciplinary intellectual framework that involves what's said in all of our literature for this meeting about computer and health, but also not forgetting the very important behavioral sciences that have to come into this equation. The challenges, many. We spent least time on this. Well, one of the biggest challenges is changing behavior, and changing behavior is going to be essential from the patient's behavior to the clinician's behavior, let alone to the rest of the business elements of the healthcare system. Transdisciplinarity, incentivizing a commonality of approach among us. We are as much to blame as anybody, and not embracing and making compromises and common approaches so we can move forward, and incentivizing adoption. Our specific test bed was to take this combination of topic and issue and focus on that really important period of time. It, not surprisingly, perhaps overlaps with the previous speaker, but it starts a little bit earlier. We had a great insight. It was one of the first comment made in our group, which is support for the patient already in sense making when they're in the hospital. So from hospitalization to home, patient-centered data sense making, from hospitalization to discharge, recovery, and health maintenance. So to reduce the patient recidivism and improve quality of life.
That was great. Okay, Fillmore group number 3, table 1. Oh yeah, that's fine. Who's representing table 1 from breakout room 3? That was Crawford, Braunstein, Shavlik. Oh, is it? Oh, did we skip Davidson? You skipped over 2. Okay, I'm sorry. Come on up. Skip them all. Yeah, that's what doesn't matter. I thought we had some order, but we're in a non-linear system now. Come on up. Yeah, we moved into the geometric space.
So this hopefully does justice to group number 2. And you'll begin to see some overlap with discussions of the other groups, which I think is the good thing. Our overarching problem that we addressed was fragmentation of care. And that has a lot of subsidiary problems like lack of coordination, data quality is uneven or bad. There is information overload, but at the same time, dearth of information available when you need it. There's non-optimal decision making. We don't have the systems in place to provide optimal decision making. We don't have the data, and we don't have time to evaluate them. So the approach that we addressed is a number of things to kind of align incentives to both provide the time, provide a multi-scale representation of data, context-sensitive, multimodal in the sense that different analytic approaches or different aggregation or summarization approaches are needed for different kinds of data, for different kinds of decision-making contexts. The challenges that we addressed are several. First of all, the overarching issue of misalignment of incentives is not just a technical problem, it's obviously a financial and reimbursement problem and reimbursement model problem. So any solution needs to involve stakeholders to, for example, primary care, if we want primary care physicians or medical home to be in charge of the care process, we have to allow enough time, we have to allow enough reimbursement to enable that provider to take that time and to do the appropriate things. And where we're faced with 8-minute encounters, we can't do that. So the pardon? You win, Bob. Oh. Oh. So, it's something I said probably, right? We also, and also there are a number of other kinds of expertise that are needed to be brought in, cognitive and HCI experts, different kinds of analytic approaches. We also address the issue of needing to aggregate data along multiple axes with sufficient detail of the data that it probably does do violence to the privacy regulations. So we need to have new ways to deal with sufficient longitudinal data aggregation on individual patients, across patients, that can allow the rules to allow that kind of research to be done. We address the need for standards and for better understanding of the appropriate analytic models and human factors ways to present these kinds of approaches. The test bed that we addressed, actually several candidates, chronic disease in the community, such as diabetes, or the handoff from pediatric to adult care, or, for example, for asthma or other, or juvenile diabetes, or any other situation where fragmentation is a primary issue.
Are you ready? Sure. You got all your gear?
I thought I was going last.
No, but you're right there.
I'm right here.
This is group 10. We're mixing it up now. So I'm Beth Mynatt, a professor of interactive computing at Georgia Tech, and my group actually delved in a number of topics, and I said we were going to do late binding on figuring it out. So right now we're going to go with data-driven personalized care. It's got a number of themes connecting with some of the presentations previously, but there's some points that were unique to our group that I'd like to draw out. So first, I'm going to do this from a computer architecture perspective. Apologies to my medical colleagues, but thinking of this as how we're going to take the data and drive it to different representations in the system. Obviously, we're going to have sensors based in the system, but we would also like to capture other information and actually creating a distributed cognition system that captures decisions, impressions, both patient impressions of their disease status, but also the decisions that are made on the fly by the different clinicians and stakeholders in the system. Treating all of that as a base of information that would be available in an open network to support distributed cognition. The types of decision making within this distributed cognition that then would be enabled. Here are some examples. Part of it is that we talked about how devices would actually become intelligent devices on the system. A very simple one of an infusion to lower your blood pressure should actually be connected in a smart network to the blood pressure cuff on your other arm in terms of creating a feedback loop within the system and something that could actually recognize a problem before it actually occurs. That for physicians connected into this network, We had a beautiful metaphor of creating, extending their senses through the different devices and through the different representations enabled to them, because it's an incredibly high cognitive overload system that we have now. And then finally, we also talked about how patients would need, in some sense, very different presentations of the same data within the system to enable their own decision-making, support for behavior change, especially within chronic healthcare situations. Part of the feedback loop that connects all of this together is two things that I would like to bring up. One is that a part of our research problem are the evaluation metrics of the system. How do we know not only when we have the right answer, how do we know when we have the wrong answer? How do we create evaluations so that we can drive progress within the space? And then the second that needs to be modeled within the system is what types of incentives also need to be placed within the system. Incentives for different aspects of patient-centered care from the physician point of view, but also incentives and persuasion that drives different behavior by patients. So within this architecture of data-driven personalized care, there were a number of challenges that came into play. First is, well, how do you deal with conflicts? We like to pretend that if all the data is just perfectly coming up into the system, that everyone is going to come to the one and correct conclusion from that data. But there are going to be different conclusions drawn by different stakeholders in the system. How do you deal with those conflicts? How do you represent them? How do you hold onto that and move forward? The second, also dealing with the notion of abstractions, is how do you maintain, how do you have a system that isn't lossy? How do you maintain the raw data throughout the system, but providing different levels of abstractions available throughout that are then accessible over time and space? And building an architecture, we don't know how to do that at this point in time. So finally, I'd like to point to some of the testbed ideas that we had, and that was actually the most a contentious debate within my group, where it was what kind of testbed would drive the right science and research within this space. One of the things that we discussed, and I suspect will get picked up by other groups as well, is how do you create a model of the system? How do you create a complex simulation that could drive and actually be the basis of knowledge for our research community? So what type of virtual representation of this type of system would actually be the basis for shared collaboration by the scientific community? In terms of physical live test beds, some people in the group felt very determined that it should be a disease-specific test bed, that we should tackle heart disease or that we should tackle diabetes. Others in the group felt just as strongly that that was the wrong approach and that that would tend to derive disease-specific requirements and that we needed to do something more holistically. Suggestions such as adopting an entire town, an entire community, and sort of a Disney, almost Imagineering approach within that space, or adopting a particular site within the system, such as ICU or the ER, and driving outcomes from that perspective. So I think the end result of that discussion was that it is a non-trivial bit of the challenges that we face, which is to understand how to put some of this research into practice so that we're actually driving quality decisions into our processes in making progress in healthcare. Thank you.
Well, just a quick environmental report. The good news is I don't think the building's burning down. Correct, Zach? Okay. But we'll have to continue to endure this Studio 54 effect. So let's go with the disco theme and bring out Casimir from Group 4.
I've been advised that our priority now is information compression. So I'm Casimir Kulikowski from Rutgers, computer science, and a lot of biomedical informatics for many years, standing in for Ted Shortliff, who had to go to an AMIA conference call. But our group had a lot of discussions. There's a lot of redundancy to what's already been said. The key, however, was if one could only identify the different configurations of caregiving groups and the different roles that people play with relation to the patient, and see what are some of the critical paths where one can exploit technology on the one hand, and where social and psychological factors are critical and very difficult on the other hand. Identify some wins versus very difficult situations. Difficult problems of modeling cognitively is one of the key issues, developing the right user interfaces, but keeping in mind the roles that different members of the caregiving team, whether it's among providers, among the family, among peer groups, young, old, you're going to have very different profiles, but trying to get a handle on where are the places where technology is likely to make a difference, where you are dealing with intractable and hard to deal with social issues. That's a central part of what we discussed. Looking at motivational profiles of people, tying that to risk behavior, attitudes towards how we deal with risk and uncertainty, and can we develop experimental test beds that will do that? Can we exploit the fact that we do have incredible technology for gaming with this, with young people? What are ways of handling this with the elderly? Totally different scenarios when you're in homes or when you're trying to keep people away from homes in their own personal home. So alignment of motivation among members of the caregiving group and where technology enters into that from a systems point of view was the key to all of this. Personal styles, so networks using, integrating continuous data streams and all of that, all of the things that have been mentioned came into it too. But if one could only come up with what is traditionally known as the clinical picture somehow, what is it that we do in integrating the patient's clinical picture, the provider's clinical picture, the caregivers, the family's clinical picture? How do we reconcile them, align them in a way that will lead to better healthcare outcomes for that patient? Very tough problem, but in a sense that's the focus of what this could be. Thank you.
My name is Blackford Middleton from Boston, and with the lights going like this, I thought this was more like speed dating than perhaps anything else. So welcome to Speed Research Proposals. We had 3 great ideas in Team 7, and I'll just mention the first 2 that we discarded: harnessing social networking to impact individual and population health and to fundamentally change the medical delivery paradigm and focus on the 30% of determinants of premature mortality that are due to social interactions. The second idea, which we discussed at length and discarded, what is interesting is really how to do better evaluation science for IT implementation at scale, and with the complexity that we're facing in bringing HIT to bear in clinical practice, as well as what's happening in home and healthcare workplaces elsewhere. The idea we focused on, however, was to address the problem of how to distill and summarize and access the right data and the right knowledge for the right person so they can make the right decision at the right time, place, context, etc. And some of these themes have already been mentioned in other research proposals already. In a way, we thought there might be creation of a health object that was very transportable, contained all the right data, contained the right knowledge, and was transparent in its transfer and whatnot between different locations of care. So the approach was to analyze how do we acquire and build and communicate and use context-specific, user-specific models of patient data. And some different ideas about modeling were discussed, all the different dimensions and abstractions, as well as families of models that might arise to address this problem for caregivers, for individuals, and for researchers. The challenges we thought that were paramount here really were fundamentally defining users' preferences and incorporating those in decision-making in a reliable way, both preferences of provider and caregiver as well as patient. What is the relevant knowledge given an incomplete state of understanding of healthcare delivery? What is a way to define context and et cetera? How to develop evaluation metrics for the modeling, the objectification of data and knowledge, et cetera, and then its implementation. And could we build a family of generalized models that this would allow then elaboration of this idea across different contexts and conditions, et cetera? And then how do we actually share the data and models in the current environment and in future environments, and how do we integrate them once they are shareable into whatever the host environment is, given the current heterogeneous state of HIT? So we thought the test bed should certainly be a medium-sized, small East Coast state. Maybe Massachusetts, no. But we needed a place where we could have a reliable opportunity or a reasonable opportunity of delivering this idea, these sets of ideas to the point of care of decision-making, both in the academic context, the community context, and perhaps in the home monitoring type context as well. How do we validate? The environment had to have the ability for validation, however, an environment which would enable measures of implementation and use and transfer, et cetera. We thought 3 example projects came to mind, of course. How might we use this health object idea to facilitate discharge summary planning and a discharge summary document? How might we use this idea to, again, as has been mentioned already, provide distributed cognitive services, perhaps based upon the object, et cetera? And how might this impact chronic disease management for patients and families and in a variety of different ways? So that was our speed dating proposal.
Hello, I'm Katie Siek from the University of Colorado at Boulder, and I'm representing Team 6. The main research problem that we wanted to look at was how do we paint a picture for an individual to understand the world and how that world affects their health. And by painting a picture, what we wanted to do was look at some data feeds. Data feeds were broadly defined, everything from your cell phones to pictures that you take, to social networking, Twitter feeds, maybe even your purchases, although there was a lot of debate about Big Brother knowing what you're purchasing. And for the individual itself, that also was broadly defined as individuals, caregivers, health and wellness professionals, and then the community at large. For the approach, what we said is we're going to look at how do we get people to either share their data feeds, who wants to share it with whom, how do we protect that, create these data feeds if they don't already have them, and then get people to use these data feeds and access them to mash up the feeds. That was our second step, was to mash up the feeds. So how do we get the data mining for the health professionals to actually make a picture, and for the individual? What data feeds are most useful for the different pictures, and what pictures are needed for each stakeholder? So everybody will have a different view. They want different granularity. This would be the first time, with all the health IT available, this will be the first time that we actually have a lifelong record of everything that person had from their birth to whatever stage in life you are. So how are they going to reflect on that data? The challenges and risks, well, the obvious one is Big Brother idea. If they know what you're buying and where you're going and such, who's looking at this data, who has access to it, what can they do with it? People making decisions without training, confirmation biases. Just because you're looking at the data doesn't necessarily mean that you understand it or can interpret it correctly. And then uncertainty of data. There's lots of data that we have in our data feeds that don't necessarily we can reflect on our health. So there's a lot of uncertainty that we have to use, especially error correction. Just because you put it in doesn't necessarily mean it's correct. So how do we fix those errors? Visualization of the data, and adoption and acceptance, especially with the feeds and the usage of these systems. We typically looked at the demonstration of design. So for that, we would capture all data feeds, and then something that was debated in our group was would the next part of demonstration of design be create a meaningful picture, or would it be using evidence-based findings to view trends? So an example given was that when we first had CT scans, we looked at the CT scans, and there was a lot of things we weren't sure what we were looking at, but it was important, so we had to capture it and then figure out what we were looking at to make interpretations. So that's the idea of, okay, we're going to make a meaningful picture first. The other idea was, well, let's look at specific groups and use these evidence-based practices to give you meaningful recommendations. This is actually a research question in itself. Which one should we address first? And then what is the main payoff? Well, what we like with this big picture idea, so you can understand the world's effect on your health, is can we identify the most important component for behavioral change? Can we give meaningful feedback to the individuals to make informed decisions and improve their health? And then for the health provider, it actually maybe will provide a better picture of what to focus on. Again, health providers' times are fairly small, but how can we give them a picture of what to focus on quickly? And then patient and caregiver community can benefit by maybe getting some decision support, and then get some personalized, meaningful, encouraged actions, and they can also reflect on health. So their current health, episodic periods within their health to see when they had some illness, and then a longitudinal record. Thank you.
I'm All right, I'm giving the report for Group 5. I'm Judith Gregory from Institute of Design, Illinois Institute of Technology. We had a very lively discussion that was quite far-ranging. We chose to focus on one problem and a proposal for a research program related to that. Our problem statement, or our problem focus, is the lack of coordination of and for knowledge sharing on various levels. Face-to-face knowledge sharing that requires being in the same place at the same time between the physician and the patient. A knowledge sharing in daily life where information about the patient's life context and activities comes back to the physician and caregivers in slow and incomplete feedback. Living with a disease and caring for a patient living with the disease. Our proposed research program for how to address this is the development of technology-enhanced spaces for medical and social knowledge and for knowledge sharing. For example, for data consolidation, for patient sensors, for monitoring the changing state of the patient. Another example we discussed has to do with real-time speech recognition and the ability to simultaneously generate the verbatim record and encoding without, while relieving the physician from recording while making better use of more sophisticated real-time speech recognition. So the development in these kinds of technology-enhanced spaces for medical and social knowledge sharing, this would include the development of a platform or a suite of tools for coordination and collaboration tools for integrating patients, caregivers, providers, medical experts, and other health professionals. For example, this would include patient empowerment tools and caregiver empowerment tools, as well as tools to support knowledge sharing amongst biomedical experts and health professionals. We did not identify a test bed. The endpoint that we came to was the proposal that to communicate this research program and the potential of such spaces and platforms, we would propose the development of a very vivid video or film that would simulate the kind of ideal interactions that could occur in such spaces and how these would make a difference. That creating such a video would give us a way to grab attention vividly and to generate the funding and support and communicate the kind of opportunities for innovation that it represents.
It's me, that's it. Okay. And is this on? Okay. I'm Rachel Nelson from ONC, and I'm not sure which group number I represent, but I'm the last one between us and lunch. Oh. Darn, so I only have one excuse to be brief, which I wanted to be anyway. And that is that a lot of the overarching themes and a lot of the group process that we went through in my group were echoed or echoes of what has already been talked about. At the end of our discussion, we have a number of papers that we taped to the wall identifying different things, different aspects, different angles we would like to address. When we came to the last few steps, we decided to articulate one challenge that knitted it all together. How do you make all this stuff fit together to do what we're really trying to do? And what we articulated as our problem statement was, how do we leverage technology to change the dynamics and the interactions within the relationship between healthcare professionals and their patients or clients or consumers to achieve the transformational outcomes we're looking for in quality, in efficiency, in patient and provider experience of the care. And in a sense, the answer to that question says, how do you redesign the system, make it all work together? What do you do? So our approach to figuring this out was to hold a competition for approaches, a competition for approaches to the idealized design. How would you build an ideal system that uses these technologies in the best way to get to the best result? By the way, we did not establish the evaluation criteria for such a competition. We did not have that kind of time. But we did identify the initial test bed that we would propose to use. And that is, after we held the competition, we would not pick one winner. We would pick finalists or perhaps semi-finalists, if you will, and the semi-finalists would be built as online accessible simulations. And the simulations that were able to engage the most participants would then be assessed on their success within their simulated success at achieving the targeted outcomes of the transformation of the system. So that, in a nutshell, is where we wound up. Again, if you want more of the richness of the various ideas we batted around in the majority of the time that we were working, we have all of those papers taped to our wall and can hand them over to the organizers.
Okay, I'm John Guttag. I'm from MIT. Our group's winning proposal or idea was to work on personalized evidence-based medicine. And we want to emphasize that when we talk about personalized medicine, we're not primarily talking about genetics, but other kinds of things. The goal is to identify populations that have a high probability of benefiting from some specific action, or for that matter, lack of action. When we talk about evidence-based, what we really mean is data-driven. The fundamental idea is to capture as many raw signals as possible, with the emphasis here on the signals being raw signals, keeping in mind that today's noise is often tomorrow's signal, so not trying to judge in advance what actually is going to be medically relevant, and also keeping in mind that the most important signals are often non-physiological, for example, behavioral or daily activities. We're interested in developing sophisticated analysis techniques to attract appropriate conclusions for populations, subpopulations, and certainly individuals. We also want to be mindful that it will be necessary to do this working with imperfect data sets. We can't assume that we'll ever get perfect data to work with. We've already seen how easy it is for different people to interpret simple notions, for example, 3 minutes, in radically different ways. The research program we talked about involves several legs. An important piece was the construction of public databases that could be used to accelerate research. We all expressed frustration with the fact that we spent lots of time gathering data that we knew somebody else already had. Methods for scrubbing the data, support of data-driven, as well as the more traditional hypothesis-driven research activities, sophisticated decision support tools for extracting information in a way that's useful for different audiences, ranging from families to patients to certainly medical professionals. And finally, that this all needed to be grounded in some set of real applications so people's feet didn't at least go too high into the atmosphere.
Okay. All right. Having just returned from Brazil on Saturday, let me say obrigado to the 10 speakers who sacrificed themselves this morning. In the interest of preserving the integrity of the 3-minute rule, maybe Susie, Zach, and I can convene later and figure out if there's some way to administer an electrical charge or something up here while people are speaking. But, you know, we just had to get it out there, right? I mean, people worked hard. I'm glad we shared. It was good. But now is not the time to opine. Now's the time to dine. So lunch is waiting for you outside. Let's get back here around 1:15, 1:20. Thank you. Sure, that's cool.
Can you,
It'd be nice if they were available.
we have the pages
You should put them up. That'd be great.
And case doesn't matter on Twitter, right?
I don't think so.
Do you want to say discovery and innovation, DIHIT?
Oh, yeah. Yeah.
Cool.
Oh, no.
Well, Ron, how are you? Thank you. Very nice to see you.